everyone. Welcome to today's webinar, Engineering Outcomes, Managed Care and Value-Based Design in Ohio Medicaid. I am going to be your presenter today. Just a couple of housekeeping items before we begin. If you have any questions, please enter them into the chat box and we'll make sure to get to those at the end of the presentation. If you need any follow-up, my contact information and the slides will be available at the end of the slide deck in an online format. You can always just give me a buzz or shoot me an email, of course. With that, we'll go ahead and get started. So first of all, just a quick introduction. My name is Loren Anthes. I'm a public policy fellow with the Center for Medicaid Policy at the Center for Community Solutions. There's my contact information there. I would ask that if you haven't already, sign up for our newsletter for the latest on health and human service policy issues here in the state of Ohio. Don't forget that we have an accompanying issue brief. I think it's in a little bit more detail than what will be presented here. Of course, in this day and age, we ask that you follow us on social media as well. And you can see my handle at Loren Anthes as well as our enterprise handle at Community SOLS. So today, just to kind of get into our presentation, first I'd like to talk about Ohio's context, why we're talking about this, what managed care means in Ohio, and why managed care is a part of our model design. The current contract, so what does the current contract say, and what does it require of plans, and how does that engagement work between the plans, the state, and providers? Some opportunities that may be available to the state when thinking about these policy issues, and then state budget update as well as a conclusion. Then we'll go ahead and take some of your questions. So first, let's talk about Ohio's context. To understand Ohio and managed care, you have to understand what preceded before it. So it's useful to comprehend fee-for-service. In fee-for-service, which still covers about 10% of the Medicaid population, the state reimburses services through a fee schedule, hence the name. The rates for each of these services are developed by the state agency in charge of the Medicaid program, and those rates only have to be sufficient enough to ensure the state is meeting its obligation relative to agreement it has with the federal government. Value, which then can be described as the amount spent compared to the outcomes delivered, is harder to achieve. The difficulty in determining value in this process is because payment amounts to providers typically reflect the intensiveness of the service provided, not the outcome that is achieved. In other words, the more specialized and acute the intervention, the more that's typically reimbursed. As a provider, it's much more economically advantageous to build one's workforce and revenue cycle around that which provides the most reimbursement. This isn't to suggest that the motivation of providers is strictly financial or that the intention of the provider is to facilitate a diabetic amputation over that of a dietetic consultation. But it can be said that the delivery system itself has been built around this model of payment, and as a nation, as a state, the amount of resources committed are not achieving the highest value in terms of the outcomes. Managed care in Medicaid is a delivery model concept where the government tries to couple flexible regulation around payment to providers with the abilities of private insurance companies to leverage data, coordinate care, and negotiate price through contracting. On an ideological level, this model also allows for a private company to administer benefits instead of the government, thereby theoretically injecting market-based economic concepts into the program's operation. Rates are developed by an actuary, not by the state. And providers can contract with an MCO and are reimbursed based on that contract. So in that way, rates can either go up or down depending on how the contract is established. There's also much more flexibility in the design of these reimbursement arrangements via contracts, meaning MCOs are not limited to what can be basically an outsourced version of fee-for-service, though they are required to provide all the same services that would be provided through the state. However, most contracts still rely on fee-for-service as a fee schedule foundation, which has been shown to be preferred by providers. And you can see here that the light blue on the bottom of those bar charts represent the amount of fee-for-service that exists in Medicaid in Ohio. And this is a chart from 2006 through 2016. And you can see that the amount of fee-for-service has decreased over time. And in fact, it's decreased even more since behavioral health was carved into the managed care program. So since the beginning of the fiscal year 2012, trying to get our slides moving here. Thank you for your patience. Since the beginning of fiscal year 2012, Ohio has paid more than $61 billion to managed care organizations. This figure represents nearly 3 out of every $4 spent on Ohio's Medicaid medical services during that time frame. Looking at the total program enrollment, 2.4 of Ohio's 2.9 million Medicaid enrollees are covered by one of Ohio's managed care organizations. So that number shrinks to about 2.2 million, including the age-blind and disabled, covered families and children, or CFC, and the expansion population, otherwise known as Group 8, once the MyCare population is excluded. The analysis of both this paper and this presentation doesn't speak to MyCare Ohio because that could probably warrant its own analysis, although a lot of the concepts are still very valid in what we want to talk about here today. Since Medicaid is one of the most significant policy investments of the state, representing nearly 40% of all dollars appropriated in the biennial budget, 5 Medicaid managed care companies act as the state's proxy for stewardship of $1 in $3 in Ohio's budget. Given the increased role of MCOs and their increased role in managing these resources, the state's contractual expectations for the plans can be examined to better understand the purpose and intention for this outsourcing. So a couple of key financial concepts. Capitation, or the capitation rate development at MCOs, differs from the state's fee-for-service rate development. First, capitation rates must be constructed in accordance with the standard known as actuarial soundness. This means that an independent actuary establishes the range of rates for all, quote, reasonable, appropriate, and attainable costs, end quote, required under the contract established by the state, though it doesn't prevent the managed care company from contracting with providers at higher or lower amounts. Capitation rates also have to be reasonable in order to achieve a standard known as medical loss ratio, otherwise known as MLR. This is an important tool that we'll talk about in the terminating section regarding value-based design, but the loss ratio signifies the amount of money that is spent on medical services versus that which is spent on administrative activities, including salary. By July of this year, the beginning of the state's fiscal year, rates will have to be developed so that a plan can reasonably achieve an MLR of 85%, meaning that at least 85 cents from every dollar will have to be spent on medical services. It can be argued that the main commercial tenet of the managed care model stems from the state's incentivization of controlled costs of the plan. The state pays the plan's rates through a capitated payment. In a fee-for-service model, this cost can be driven in part by how an individual utilizes services. If individuals may use many higher-cost services, this average amount will go up. In capitation, MCOs can keep a portion of the money they do not spend, meaning they have a natural economic incentive to keep costs down. For that reason, utilization management is a definitional activity of MCOs. So I want to talk about why managed care. I mentioned utilization management, but utilization management comes in many forms and has come under critical scrutiny by doctors and patients alike. First, it may be worthwhile to better clarify what I mean by utilization management. According to the National Academy of Medicine, utilization management is a set of techniques used by or on behalf of purchasers of healthcare benefits to manage healthcare costs by influencing patient care decision-making through a case-by-case assessment of the appropriateness of care prior to that care's provision. Pretty wordy, but perhaps the most familiar example of utilization management comes in the form of prior authorization, or PAs. PA is a requirement that the clinician seeking to deliver a good or service for a patient obtain approval from a payer or an insurer before that payer can reimburse the clinician. For example, if there's a particular medication that a physician prescribes, but a lower cost generic alternative exists, the MCO may require the physician to seek prior authorization before the brand name drug is covered. The Ohio Administrative Code has established parameters around prior authorization, which prevents the plans from having hard limits on services unless fee-for-service has the same. Results documented in research on the effectiveness of these in terms of cost, quality, and access are often varied. In a comprehensive 2012 study from the Robert Wood Johnson Foundation, research suggested that the impact of managed care in the aforementioned metrics were sort of a mixed bag depending on what state you're in. Costs may not have been reduced, although there were savings, and usually tied to utilization reductions because of managed care. Access was not reduced either, but evidence suggests that access increased for primary care and decreased for specialists under an MCO model. Additionally, any improvements in quality were indiscernible, in large part due to the lack of useful data, which we'll talk a lot about in our terminating section. Importantly, it's been shown that quality outcomes, when compared to employer-sponsored or Medicare Advantage population, tended to be lower in Medicaid managed care. This is probably due to the nature of the population. Being low income in and of itself is a high risk factor. For physicians, managed care has and continues to be seen as a barrier to care. In a recent survey conducted by the American Medical Association, or AMA, 92% of doctors stated PA harms patient access. This underscores an important point about the economic conditions of healthcare as something in which consumers engage. Payers, whether that's the government or a managed care organization, are the consumers of healthcare. Individuals, i.e. patients, regardless of their coverage type, do not directly purchase services, nor are they equipped with the information necessary to be rational economic actors in this process. So considering both the research and economic context, the effectiveness of Medicaid managed care must be judged by the policy interventions of the state, not the individual patient, in terms of achieving outcomes. To do this in a meaningful way requires an examination of Ohio's current contract and the ways in which it has sought to achieve value through reimbursement design. So let's go ahead and talk about Ohio's current contract. The agreement that exists between the Ohio Department of Medicaid and the managed care organizations is standardized and organized in several sections that address federal requirements, as well as state expectations and mutual responsibilities in regards to data, benefits, payment, and quality. This exhaustive 257-page document has 17 appendices, but we'll just talk about a few items discussed today. On the right hand, you can actually see the entirety of the contract in sort of a graphic form, which was certainly a lot of fun for me to read. And for those of you who have not done so, you should certainly take a look. But we'll talk about this a little bit. The MCOs also use this contract statewide, and in each of the 3 regions established by the state. This is different than years past where different plans could operate in different regions. The MCO has to have a certain amount of executive organization with expectations that it respond to state requests, adopt state policies, and make staff available for meetings and events. In particular, plans must have a behavioral health administrative director who is licensed to deliver services in the state of Ohio. This is something that not only addresses the management needs of one of the highest cost populations in Medicaid, those with BH needs or behavioral health needs, but also acts as a structural design response to the state's efforts to have the behavioral health population enrolled in managed care, which happened just last year. Interestingly, plans must also have similar administrative leads for early and periodic screening, diagnosis, and treatment for children, otherwise known as EPSDT, and quality improvement, QI, and community engagement, like connecting people to employment services. MCOs, unlike the state, are not limited to those services covered in fee-for-service through the state plan. While MCOs must notify the state of services they plan on offering in addition to fee-for-service, they can also offer other services based on geography and identified member need. Flexibility allows the plans to mitigate risks in paying higher cost services by addressing other essential needs, such as housing and transportation. In addition to this flexibility, there are some required notifications that plans must have with their members, for example, pregnancy-related services, and providers, such as data regarding EPSDT. For some populations, the state is more prescriptive about what is required of plans, including during transitions of care between settings and services, which are historically known as inefficient points in the delivery system. This includes, but is not limited to, working with expectant mothers to coordinate care immediately upon discovering pregnancy, honoring previous prior authorizations for members, having region-specific family councils advise MCO operations, and coordinating with community behavioral health centers on care for members with significant BH needs. MCOs also have the ability to offer feedback on individual providers regarding their performance on evidence-based guidelines and quality metrics, some of which is mandated. One example of this mandated provider interaction is tied to the maternal mortality issues, where the state requires additional payments to providers who convert 1% of cesarean section rates to vaginal-based deliveries. That's a strong predictor in maternal and infant mortality. Managed care do not make clinical decisions about cesarean sections, and providers still provide the procedure when it's medically indicated. MCO's main source of data comes from claims, which represent information on those services for which they provide payment. Providers who contract with MCOs are considered to be on the MCO's panel. The federal law basically outlines what is required of these standards with a focus on access. Claims data can be shared with contracted providers, but data and reimbursement may also be established with non-contracted providers if it allows the patient to receive necessary services, but does not always entail sharing discrete outcome-related data. Regarding the panel, the state mandates that there be a certain number of primary care providers so that the total capacity for a single primary care provider is no more than 2,000 members. The contract also requires that other providers, including hospitals, OBGYNs, certified nurse midwives, certified nurse practitioners, vision, dental, behavioral health, pharmacies, and other specialties as needed. The state ensures that this network of providers is meeting federal standards of adequacy and that enrollees are able to determine what providers are available. If an MCO fails to meet these standards, the state can impose sanctions. The remaining sections of the contract outline information relative to fraud, waste, and abuse, financial performance, including the medical loss ratio, and quality. Regarding financial performance, plans must report on the amount of clean claims submitted by providers, with requirements that 90% of all claims be paid within 30 days and that 99% of claims be paid within 90 days. In some respects, this measure can act as a proxy to determine if utilization management efforts of a managed care organization are effective without compromising continuity of care. According to the most recently available public report, the complaints tend to be concentrated with providers, not patients, particularly around issues of payment. It should be noted that the plans were generally successful at processing claims within the state guidelines, with the average time ranging from 2.6 to 7.2 days. As this information has not been updated since the inclusion of behavioral health into managed care, this data will be important in evaluating how community-based behavioral health providers are faring under this system. So let's talk about statistics for a bit. Population health as an insurance strategy. And I think this really sets the stage for the rest of the conversation we have around value-based design and what that means. So first of all, let's define risk. Risk in insurance terms is the likelihood of an insured service occurring. In a population, the risk is distributed based on observations and experience. Observations in this way are the same thing as utilization patterns. Historically, in healthcare, we are agnostic to risk, i.e., we pay for services rendered. This is what fee-for-service is all about. The incentives align then with providing more services at higher prices. When we think about population health, when we think about value-based design, the idea is to try to shift the risk back to providers. So as the state, what you're essentially trying to do is front-load the investment to diminishing risk. Payments can be upfront, global, or at risk, meaning you keep what you don't spend and you're paid for achieving quality. You're reimbursed by lowering the risk exposure of payers like insurers, Medicare, and Medicaid. Risk, like I said, is the likelihood of an insured service taking place. For this reason, in the context of population health, there are individuals who are lower risk, less likely to receive a service, and higher risk, more likely to receive a service. This process of dividing a population based on risk is known as stratification and is a requirement of the plan. The stratification process must also include using a standardized risk assessment tool for the purposes of stratification within 90 days of enrollment. In addition to risk, populations must also be divided into streams, which reflect the public health orientation of the state. These 4 streams include women's health, behavioral health, chronic conditions, and healthy children and healthy adults. For each of these populations, the MCOs must outline specialized services and resources that align with the stream with their associated level of risk. It is within this framework of population-aligned, risk-informed services that managed care has the highest potential for value creation. So talking about specialized services for a second, included in these specialized services and resources are requirements for care management, risk assessment, individualized care plans, staff availability and identification, routine communication requirements, transitions and technology which documents all of these pieces. There are also requirements to work in specific projects of the state, including comprehensive primary care or CPC initiative, behavioral health redesign, co-management of home and community-based waiver populations with waiver administrators, and case management of individuals leaving correctional facilities. Plans must also engage in activities which utilize statistically based quality improvement science and engage in activities as directed by the state to address health disparities tied to social or economic disadvantage. To understand how MCOs act as agents of ODM in effectuating population health, it may be worthwhile to focus in on CPC and behavioral health redesign as outlined in the contract as examples. So CPC, comprehensive primary care. Comprehensive primary care practices basically try to enhance a physician's influence on patient outcomes by providing an alternative payment model to support care management, community connectivity, population risk stratification with identification and tracking of the highest risk patients and team-based care, just to name a few. A second aspect of the payment model includes an opportunity to participate in shared savings for practices who meet population and performance qualifications. In the context of CPC, MCOs are required to work directly with practices that have signed up for the program. This includes information sharing, the identification of needs, common case management, and data regarding attribution and utilization. Unlike other parts of the managed care program in Ohio, this requirement to commonly case manage populations is unique. The 2018 Health Affairs National Review of the model did not show any meaningful results in terms of outcome or cost, though other analysis suggests that the project needed time to mature, and the physicians were generally more satisfied and thought the program was worthwhile. If you take a look at an example of what this looks like in the reports that are provided to providers, you can see how really what we're looking at is sort of a bell curve organized a different way. You see the average cost, where you are, and what your opportunity is for basically earning money back through achieving value. If we kind of think about this a different way, here's an example of just one element where you see the category where it's a stream, right? And the payment is organized by stream and by plan. And then it gets expressed as a risk band with key conditions like asthma and diabetes. Information also shows categories of care and ranking within these measures, such as ER or emergency department utilization, pharmacy, and durable medical equipment. So in this example, you can see here that in terms of the total Medicaid, this particular physician might be doing well, but also there's opportunities for improvement depending on which plan they may be working with. So really this is about transparency of what you're doing in the context of your office as a clinician and how that engagement has to work or could work with a managed care plan. Now, talking a little bit about what we typically see or what often we hear as measures of quality and measures of performance. We see this. We see this report card that the department has developed for managed care, ranking each of Ohio's plans based on getting care, doctors' communication and service, keeping kids healthy, living with illness, and women's health. While this two-page document may be a useful consumer tool in plan selection, it does little to explain the exact achievement of quality. The state, pursuant to federal law, must have an independent evaluator examine how managed care is performing relative to quality benchmarks, but also develop individualized data around utilization, encounters, patient experience, and case management. Regarding paying for quality specifically, Ohio created a pay-for-performance program, or P4P, which has evolved over several years. P4P relies on using a common set of measures established by the National Center for Quality Assurance, or NCQA, known as the Health Care Effectiveness Data and Information Set, or HEDIS. The Agency for Healthcare Research and Quality, or AHRQ, is also the source for the Consumer Assessment of Healthcare Providers and Systems, or CAPS, which evaluates patients' perceptions of care they receive. I know that's a lot of acronyms and sort of like alphabet soup, so I strongly encourage you to take a look at our issue brief to distill some of this. But a look at the state's reports on performance around HEDIS, including those items outside of P4P, help identify whether or not P4P policy is effective and how the plans perform relative to national benchmarks or the state's efforts to incent higher performance. So taking a look at this, this is some data I pulled together on Ohio's P4P program through 2018. In October 2018, the state of Ohio issued a report on the P4P program. Until last year, P4P in Ohio tied 6 measures to a P4P payment out of the 90-plus measures that comprise HEDIS, and depending on the achievement in those measures, MCOs were eligible for a bonus. These measures included follow-up after mental health hospitalization within 7 days, timeliness of prenatal care, postpartum care, controlling high blood pressure, diabetes control, and adolescent well care. You can see this in the context of some of the public health priorities of the state, whether we're talking about the substance use disorder crisis, or we're talking about infant mortality, or talking about just the burden cost-wise of chronic diseases. These measures try to provide some tools to the state to better engineer how those things are addressed through these contracts. The overall performance of MCOs relative to those P4P HEDIS measures went up, and payment went up as well. As mentioned earlier, P4P is based on a sliding scale, where the minimum payment is made at the 25th percentile, and the total bonus is earned once it gets above the 75th percentile. For those 6 P4P measures, a low of 66.7% of the MCOs exceeded the 25th percentile nationally in 2013, while 83.3% of the MCOs exceeded the 25th percentile in the most recent year. Additionally, for the remaining 20 HEDIS measures tracked by the state, MCOs have increased performance above the 25th percentile from 73.9% to 85%. The state could increase or decrease the minimum or maximum percentiles for P4P. It should be noted that these are relative measures, meaning the percentile is based on a national comparison for any given measure, not that of a true rate of completion, i.e. these are not tied to a bell curve. As mentioned previously, the state contracts with an independent evaluator to determine quality achievement. The recent review that was conducted by the Health Services Advisory Group, or HSAG, who looked at HEDIS and CAHPS information, evaluating the MCOs based on all these measures collected by the state, categorized them into the 4 population streams highlighted earlier. This presentation will now take a look at the CAHPS results of the MCO, as they're not tied to payment for P4P, but every plan was above the 25th percentile for all measures, with the most common rating being above the 90th percentile, indicating Ohio enrollees are generally satisfied with their plans and their contracted providers. So talking about population streams, above is a table built from the latest 2018 review, which shows how the managed care organizations met the HEDIS minimum performance standards for each of the population streams. It's worthwhile to know that no single measure in the healthy children or adults or women's health streams had the highest ratings. Only the following measures, all of which are tied to pharmaceuticals, earned the highest ratings. So a summary of what's going on here. The HEDIS measures and the P4P program seem to have an effect on the population health management of the MCOs. However, as of April 2018, the P4P program as a bonus structure was sunset, and a new withhold arrangement wherein 2% of the total capitation awarded to the plans will have to be earned back through the achievement of quality was installed. For those dollars that are not earned, a bonus pool is available to those which achieve above the 75th percentile. As opposed to the previous P4P program, the quality measures in state fiscal years 2020 and 2021 will be tied to cardiovascular disease, diabetes, behavioral health, and healthy children. This is outlined in the quality indices and scoring methodology established between the MCOs and the state in the contract. This program includes the use of HEDIS, like the rest of P4P, but is a complex calculation that includes weighted scoring tied to a number of measures linked with each of the 4 quality measure areas. This calculation then determines a final index score, which is then used to determine the amount of the withhold that is remitted back to the MCO. As with the state's contract, generally, these measures can be changed, augmented, and revised. This is in part to accommodate the state's focus on moving reimbursement to a population focus as opposed to any single measure as active management, which is required more so than the achievement of any single measure. In sum, managed care is an agent of the state's efforts in the state innovation model through CPC and is responsible for carrying out the population health management priorities established by the department through the P4P program. Since 2013, ODM has built upon its initial contractual arrangement to tie more dollars to value and prescribe greater attention be paid to high-risk, high-cost Medicaid enrollees, as well as performance improvement projects based on historical performance. Beyond specifics, the state's contract with MCOs includes a provision where at least 50% of all aggregate payments to providers through MCOs be value-oriented or face sanctions, creating an incentive for plans to contract more effectively in a general way. With 2020 fast approaching and the current rebidding process underway, existing plans' effectiveness during this contractual cycle may be worthwhile policy to maintain. Now I'd just like to talk a little bit about some opportunities or considerations as the state moves forward. First, according to national research, it takes about an average of 17 years before evidence makes it into clinical practice. In this research, the author suggested that some of the issues stem from an overwhelming volume of research and diffusion of priorities and responsibilities in implementation. In other words, the process of implementing the best medicine possible is not always consistently and standardly communicated with clinicians, therefore leading the system to be defined by fragmentation. In the context of Ohio Medicaid, many of the efforts over the last few years can be seen through the introduction of standardized value-based concepts into clinical workflows. HEDIS, CAHPS, P4P, SIM, etc., are all programmatic installations of value-based design. According to the data that's available, these efforts are having a positive impact on cost and quality, but not as much as they could. Some of the current system may not be achieving its full potential because the arrangement of the delivery system is asymmetric and asynchronous. Asymmetry is happening because the types of data that exist are disparate and not readily shared through a common tool in a broad way. Providers have clinical information and healthcare records, which is often included in Ohio's Health Information Exchange, CliniSync. And HIE, the information exchange, to explain, allows doctors, nurses, pharmacists, and other professionals to appropriately access and securely share a patient's vital medical information electronically, improving the speed, quality, safety, and cost of patient care. While this tool is accessed by more and more providers, there's no mandate to use it, and community-level agencies and insurers do not have access. This means that the clinical information, the data, on any given patient is not always available to the person or persons responsible for delivering care. If some of the highest value services come in coordination beyond clinical spaces to non-clinical services, this is a significant continuity issue. It'll be worthwhile to see how the withhold arrangement compels MCOs to think differently about the ways in which they collaborate with providers. Perhaps this sort of tool can be equally shared with providers, allowing MCOs to automatically adjust their contracted rates with providers relative to measures tied to quality. In other words, MCOs and providers should share the penalty. Beyond this, the state could consider doing more to better enable information exchange between plans and providers. While Ohio has previously contemplated transparency laws and is actually a part of the current budget, those are focused on the patients, the least empowered economic actors in the commercial process of healthcare. While some may say that this is the exact logic and thus the basis for such regulation, it actually has been shown to increase utilization and costs, which is the opposite of the desired effect. Still, if the state could facilitate a broader, standardized use of Ohio's HIE and extend it to community-based organizations, that may be a useful application of transparency to better promote market efficiency. Additionally, the state could develop a comprehensive, comparable all-payer claims database or an electronic clinical quality measures database, which include medical claims, pharmacy claims, dental claims, and eligibility and provider files, all collected from public and private payers. For example, Oklahoma has a system called MyHealth, which links a web-based platform to providers that can connect and share medical records of patients and provide better transitional care with community organizations. The state could also geographically proliferate or encourage work through regional improvement collaboratives, or RICs, which can act as a broker for this information and guide quality improvement efforts. This sort of integration, regardless of mechanism, has the potential to significantly reduce harm, waste, and improve outcomes. Importantly, data on quality achievement, while publicly reported for payers, is not reported for providers and Medicaid. Even in the context of payers, it's confusing and technical. To that end, ODM should consider hosting an online site where elements of data are located in a media-friendly format that shows how Ohio providers are achieving quality by provider. An example of reform: if Ohio continues to use the structure of HEDIS, it should review which measures are included and to what degree they are achieved. For example, Ohio's children are victims of lead exposure across the state, with concentration in cities like Toledo and Cleveland. HEDIS has a lead screening measure, and Ohio is currently underperforming in those screenings, though the governor has cited lead prevention and screening as a priority. For public health crises like these, Ohio could make the P4P incentive or withhold more significant for a period of time to concentrate on the issue through that measure and consider tailoring any given measure to the needs of a given geography. What's more, for those dollars that are not earned by providers and plans, a non-GRF fund could be created or dollars could be allocated to provide resources for critical supports. In this example, around lead, money could be allocated to Ohio's Housing Trust Fund, Ohio's Lead Safe Fund, or as state match in Ohio's abatement program to the State Children's Health Insurance Program, or SCHIP. And it should be designed in a way to not affect the joint Medicaid oversight rate limit, given its potential to decrease costs long term. In 2018, the Center for Medicaid Policy, along with the Center for Community Solutions, authored a number of briefs on social determinants and their impact on Medicaid. While a number of the interventions were outside of the program, for example, increasing public transit funding as a way to address transportation issues, a number were also possible through intentional Medicaid policy design. Many of these interventions, borrowing from other states, relied on the use of demonstration waivers to address these issues. Outside of the waivers, though, there are policies ODM could consider as ways to increase accountability for plans and providers to address social determinants as a cost-saving measure. A couple of examples. Number one, required plans to provide incentives to providers who screen for non-medical problems. An example, California is considering a mandate that requires screens for adverse childhood experiences to be included in their early periodic screening, diagnosis, and treatment of child visits. Another example, Ohio could require a standardized social determinant screening tool in the 90-day screening with managed care and their assistants, and mandate that information be shared with the principal accountable provider for the patient. So in other words, when they do that 90-day assessment, Try to have some level of social determinant screening and mandate that the plan share that information with the primary care provider. Number 2, allow non-traditional services to count towards the medical loss ratio under the, quote, in lieu of, end quote, standard. An example of this, home visitation for a prenatal visit in lieu of an office visit. Number 3, develop metrics built on transitions to care across clinical and non-clinical settings. An example of this, develop a metric based on referrals to specific community-based services and tie it into the P4P program. All right, so just a quick note on the state budget. We actually have a webinar coming up this Thursday that we'll get into a little bit more detail here. But just a sort of a quick brush here, there are a number of pieces around managed care that try to address some of these issues. There's also some other pieces around here regarding payments to certain types of providers that may actually disrupt or provide new market entrants, if you want to think of it that way, into the managed care product offerings of the state. Here's what I think generally. These arrangements with managed care are immensely complicated, and they have to be sensitive to the needs of populations and the economy, right? Medicaid is a counter-cyclical program, which means when the economy is not going so well, Medicaid tends to spend more money, which makes sense. People might lose their jobs, they might lose employer-sponsored insurance, etc. I think the more and more we try to put into statute what our expectations are of plans, number 1, we're tying the hands of the department to be sensitive to those needs. Number 2, I think there's legal questions about whether or not some of these items are possible. How do you ensure that things that you're putting in the contract are reasonably achievable? How do you ensure that there's a certain amount of actuarial soundness? If the state at the same time is saying, we would like the Joint Medicaid Oversight Committee to limit spending in the Medicaid program, but then asking the program to do all of these things, how does it do those things at the same time? I just think it requires some level of analysis, and my general thought here with any policymakers would be that if they are going to ask for certain things of the department, to give them flexibility, and whatever the provisions they put forward, that it has to comply with federal standards of actuarial soundness and be something that can be reasonably achieved by managed care organizations. What's more, if hospitals are going to be allowed to organize and offer their own managed care insurance products, they should be required to better contract with community-based organizations. We know that, if you look across the spectrum economically at what's happening with major systems, there's a lot of consolidation, a lot of mergers and acquisitions. Typically, in most economic sectors, this would lead to lower prices, but not in healthcare. So I would make the argument that you would need to make sure there are strong controls in place so that that kind of vertical integration and that kind of scale doesn't create more problems than you intended. All right, so our conclusion, and then we'll answer into questions and answers. And please, if you haven't already, please enter any questions you may have in our chat box. Ohio's Medicaid program is privatized with managed care acting as a steward for Ohio's efforts to achieve value. Whatever the delivery model is enacted through policy, there are commonly shared values of a better experience for patients and clinicians, lower costs, and increased quality. That's the triple aim. Across all of these values, the United States is behind, and Ohio is a laggard in the United States. Given the difficulty in transforming this complex system, particularly in a program with the depth and breadth of Medicaid, reforms, understandably, take time. It is with this in mind that an examination of the data is necessary, and the data tells us that we are slowly improving. While there are some successes to be had in innovations over the last few years, more can be done, particularly in the areas of social determinants and transparency. Contracts with managed care organizations, which receive billions of taxpayer dollars, should be designed in such a way that we maximize their value to create an efficient and effective delivery system. For this reason, and while the legislature should demand transparency from the Ohio Department of Medicaid, it should entrust ODM with the complicated, ever-evolving work that only an executive function could offer. If anything, the General Assembly would be well advised to transition its political focus away from individuals covered by Medicaid, who are not directly responsible for any of these expenditures, to the managed care organizations and the providers that directly receive the $27 billion Medicaid represents. If we know empirically that costs are the result of a combination of social determinants and price, then our system should be engineered to address social determinants and price. Managed care, with its ability to see across systems and case manage enrollees, may currently be in the best position to navigate the non-clinical factors that affect outcomes. This management should be done in collaboration with even at the direction of community-based organizations that manage the most complex patients with the highest needs. Similarly, providers must be held to a higher standard of care, which is simultaneously agnostic to the source of patient coverage while considering the ways in which their choices affect costs, particularly when patients are unable to address their most basic needs. The Ohio Department of Medicaid, under the direction of Governor Mike DeWine, has a great opportunity to redefine Ohio as a high-value state for everyone, including the 1 in 2 children born in the United States enrolled in Medicaid. Through a careful examination of our options, a commitment to improvement, and a bit of engineered collaboration, Ohio will achieve that goal. So with that, I want to now go ahead and try to answer whatever questions you have, and I'd be happy to do so. So the first question I have, and I'm flying solo today in terms of technology, so give me a second here. So the question I have is, can you speak to how the role of the managed care case manager differs from a case manager type roles with other agencies responsible for Medicaid authorization, such as a board of DD? That's a really interesting question. I think what we have to understand here is that it's about what the case manager does and who should do it. Where is the best place to provide that case management? And I think that changes population to population. I have worked for behavioral health providers before. I've worked in a major hospital system. I've worked for the Department of Medicaid. Case management is the highest value function that you can have in healthcare, right? If you're able to connect the dots for patients and do so efficiently, you're going to get the outcomes that you want to see. Now, that's easier for some populations and not easier for other populations, going back to those bell curves. Like for me, I might be easier to case manage than, say, a child with significant developmental disabilities, right? Because they may have complex pharmacological needs, they may have complex medical needs or durable medical equipment needs. They also might need access to day-to-day services, so that someone can help them with their activities of daily living. All those things can be pretty complex. Now, the question is, should that happen on the managed care level or should that happen on the DD level? And here's what I would say. I think that it has to be a both-and sort of approach, and that we need to evaluate who is most empowered to affect a positive outcome. So I know I said I wasn't going to talk about my care, but in my care, one of the things that they saw during the first year was that the AAAs, the Area Agencies on Aging, were really good at coordinating waiver services. And initially in the design, this wasn't a mandate of the state to the plans. That changed over time. Now the AAAs receive some money to basically do that, and waiver services are better connected and patient experience went up. So I think it's sort of a case-by-case, population-by-population basis, and we should see it as an ongoing quality improvement project. Our next question here, do you see managed care's umbrella being expanded either to early intervention or long-term services and supports? I think so. I think, at least with the CASIC administration, their stated goal was 100% managed care. And I would say this, I don't think that managed care on its own, or at least the way it's currently designed, necessarily does anything negative, right? I think there's always questions of access, but according to the research, most of that comes from providers who don't like working with the plans, or they feel like the only time they get contacted is when, the plan says, oh no, we can't allow for that service to be reimbursed, et cetera. So I think what really needs to happen here is if this is going to take place, early intervention, long-term service and supports, there has to be some level of, like I said, engineer collaboration. So I imagine this will be the case, but I also have personally sort of an expanded view of what managed care means. To me, managed care is just the outsourcing of benefit administration from the government to private entities. And those private entities, in some ways, in my opinion, are like employees of the state. So just like you would manage your employee, you need to manage these contracts, and there's a lot of reasons to do that. I would say about 27 billion reasons to do that. Another question, on social determinants of health, does money used by MCOs to address social determinants of health reduce the amount of spend on their health care? This is a really good question. I think the answer is yes, but I think we don't really know. There isn't really, outside of what the plans directly put out there in their own report and researching, I don't know if we really know the answer to that. At least I don't know in any sort of independently derived way. All I can say is, when I talk to individuals who rely on managed care, some have found the experience to be really good, right? Their case manager was able to connect them to housing, to be able to connect them to food, that sort of thing. Other cases, they never hear from the case manager. They don't even know they have one. This is part of the fundamental problem with, I think, the economic relationship between patients and the rest of the delivery system. We have to be more patient-informed. And where case managers could intervene, I think we need to just be a little bit more aware of what is required there, and maybe ask the state to publish more. So I think this withhold arrangement will be interesting. I think if we could get more information on how that spending works and how that's included, I think that's helpful. But also, if we're looking at, say, in lieu of services in the medical loss ratio, that's something we could track. So if we're able to track that sort of thing and have regular reports, we can slowly improve, and incrementally, I think that's what we need to do. Next question. How would ODM foresee MCOs working with developmental disabilities waiver system when 40% of waiver reimbursement is paid out by local dollars? I don't know. That's to be honest, that's a question you probably have to ask of ODM. Although, I think you can look to the behavioral health system. I wonder if this is something similar, or maybe the state is interested in something like elevating the dollars to the state level or not. That's probably a little bit deeper of a conversation than you could have in this chat, but I'm more than happy to follow up with you, Rodney, who asked that question. All right, next question. If a hospital is addressing social determinants of health with a medical legal partnership, should the MCO pay a premium on integrated care? Really good question. I think here's where I feel about like the social determinants issues and whether or not managed care should pay. There is a line of thinking that says if you're doing something that is making the managed care organization money by mitigating their risk, you should be able to negotiate that with them. Meaning, if you're bringing a value to managed care plans through the partnerships that you have with community organizations, they're probably saving money. And if they're saving money, they're making money, right? This is the natural incentive of managed care. Now, if they're unwilling to contract with you in that way, I think the question is, what do these other sort of provisions say around meeting that 50% threshold in value-based arrangements, et cetera, do? I think this is why I'm personally very interested in better integration of clinical and claims data and mandating better conversations. Because to me, I'm sure that if you're thinking about a medical legal partnership with many folks, that you could very easily understand what their needs are, what their disease profile is, and how those things relate to the different incentives that the state has built in around population streams, et cetera. So if you know that when those patients receive the medical legal services that you're identifying, are better able to manage their diabetes, better able to address hypertension, well, that's something that's making the plan money. And in a withhold arrangement, they're going to earn that money back. And I think it's really about trying to bring them to the table to say, hey, listen, we know that you're making money here. We know that we're able to help, or at least can we engage in some sort of data project to validate what we think is working. And I think that's where the opportunity is. So there's that sort of free market principles that are at play there. However, it's complicated work, and not everybody's there, and two, it's often just a scale game. So I think part of the question is, to what extent do these issues need to be broadly defined in the contract with managed care? And I think that's what the state is trying to do, and really create conditions for providers to engage plans and for plans to engage providers around these things, so that things like medical legal partnerships can be more helpful, so that you can get a case management fee to address those sorts of things. So I think that's where the opportunity really lies. Yes, everyone will have a copy of these slides sent to them, or at least online. If you don't get a copy, just email me. That would be, I'd be more than happy to follow up. Another question, do you see plans adjusting for social risks such as homelessness and value-based arrangements? Do you see plans subcontracting with narrow networks such as hospital systems that limit the choice of providers? So there's sort of two questions in there. Do you see plans adjusting for social risk? Yes, I do. I think, this in Massachusetts, for example, I talked about risk stratification and the assessment tool. In Massachusetts, they're trying to have a social determinant screening tool inform the risk assessment of plans. I think that that's kind of the direction we may be going nationally in some of this policy design, barring the elimination of Medicaid or block granting or some other sort of large environmental disruption. So one way or another, they're going to have to pay attention because really, you think about the bell curve. If we believe that social determinants are affecting cost, you just have to shift the money towards addressing that cost, and naturally these things will sort of be addressed. The question is, is the data the right way? Is it being measured appropriately? Is it evidence-based, et cetera? So the subcontracting question is a little bit different. I think the plans right now can subcontract out most of their services if they wanted to. The question is, do they want to? And second, do the subcontractees have the appropriate credentials? So one thing I learned was that in order for a plan to subcontract out case management, that the subcontract also has to be NCQA certified as a patient-centered medical home. Otherwise, it could potentially compromise the patient-centered medical home certification of the plan, of which all of them are required to be. In the MyCare example around the AAAs, the state sought an exemption. I think for FQHCs, most of them are NCQA Level 3 certified patient-centered medical homes. So ostensibly, you could negotiate a contract like that. I think that there's probably some level of engagement that needs to happen with the state to say, hey, what can we do to compel better subcontractual relationships? Or maybe go to the plans and say, forget subcontracting. You give us a per member per month, and can we enter it into a new sort of financial arrangement? I think that those are definitely potential. The second question to that, do you see plans contracting with narrow networks such as hospital systems? Well, first of all, plans basically have to contract with hospitals. There are certain hospitals, even I think children's hospitals, plans have to be contracted with them. So that gives hospitals a tremendous amount of negotiating power. The reason why narrow networks are interesting is because, again, if you say treat a disproportionate share of the Medicaid population or any population in any market, you're going to have more say about what could be established in that contract. The bigger you are, the more leverage you have, right? This is traditional sort of healthcare economics sort of stuff. There's also ways to affect market share of plans through contracting, and I'll give you an example. When people select a managed care plan, about 2/3 of the time, they don't actively choose it when they first enroll. They oftentimes are just assigned to a plan based on an algorithm, an eligibility algorithm of the state. This eligibility algorithm is influenced by or is weighted by how a plan might achieve certain measures around infant mortality. So that means if I'm enrolling in a plan as a pregnant woman and I'm being auto-enrolled, I might go to Plan A over Plan B because they do better around infant mortality. So there are ways to engineer market share plans in this passive enrollment process. I think that also carries a lot of potential there to sort of disrupt that narrow network piece. And then I think, too, that probably requires a deeper examination of network adequacy standards. Another question. In general, what are the legal restrictions on non-clinical services that Medicaid can pay for? Basically, Medicaid can't pay for stuff that isn't medical services. So if it's not medicine, it can't pay for it. It can't pay for room and board, except in the context of, say, like nursing facilities. So, sometimes you hear like, well, why doesn't Medicaid pay for housing and that sort of thing? Currently, it can't do that. Now, some advocates around, block grants might say, well, that's why block grants are useful because, they can provide more flexibility to address the things that you need to address. I would ask anyone who may be interested to check out our other research in this area, but I don't know if that would be as effective. That being said, managed care does have some more flexibility under the in lieu of standard that I highlighted earlier, and is able to pay for things that Medicaid traditionally cannot pay for. Typically, this is tied to still medical services or really case management. So let's say that you are a provider who's doing free case management relative to people who are housing insecure, or rather that case management is something that you do in kind with your employees. If Medicaid could pay you for those services, well, then it would sort of offload your fixed costs associated with hiring that employee, right? You could actually pay for that. So that displaces some of the money, which is not exactly the same thing, but something similar. Another question here. Seems there is tension between adjusting for risk in payment arrangements and addressing risk factors in patient lives. Is there? How is Ohio dealing with this? Yeah, so, I think it's a question of how we measure risk. I obviously am not at the center of the data universe of Medicaid or any of the managed care plans. So I don't know what the data is telling everyone, but what I can say is what the research suggests, right? What the CDC suggests around social determinants. And that is when you think about how the medical system addresses outcomes, a large part of outcomes are not determined by what happens in a clinical office, right? This is why we pay attention to things like housing, transportation, food insecurity, trauma, systemic racism, et cetera. You need to invest in understanding and unpacking those issues because those explain why there's disparities, let's say, in infant mortality between African American women and Caucasian women, despite having the same level of education and income. These sorts of things are critical. So can payment arrangements address those things? I think they certainly have the potential. But this is why I'm stressing flexibility. The more and more we try to say, well, the state law should address these things, or we should pass a bill that says that, it needs to focus in on these things. I think the more that we decouple those things outside of Medicaid that are also responsible. And what I mean by that is, why are we going to give money to a managed care plan to address transportation as opposed to just building an adequate transportation infrastructure network? Why don't we just invest in public transportation? We know that we could do that. It doesn't cost us any dollars in Medicaid, and it will improve outcomes. So I think, it's not just a measure of what happens in health insurance terms, but it's also what happens in the rest of the state budget, and we should be paying attention to that. In housing, it's the Ohio Housing Trust Fund. In transportation, it's public transportation. In food insecurity, it's ABOD, work requirements, right? These are things outside of Medicaid that can help address Medicaid costs. But there are still tools that we could look at, and I think that this assessment tool that we're talking about is something that's really worthwhile, let's say, on the managed care side. And then I think ACEs screenings are something that's really worthwhile on the clinical side. I also teach at Ohio University's Heritage College of Medicine and work with a lot of physicians, primary care physicians. I think most people will be really surprised to learn how little penetration there is in awareness of pediatricians and other primary care practices about that screening tool, which is really a risk assessment tool. So how can you align those sorts of tools, those sorts of measurements in the clinical side of things with the claim side of things and with state policy? And really that's sort of what I'm trying to put forward here. The last question I have, and then that will conclude our presentation for today, but of course you can always follow up with me. Are there any efforts to keep attribution of patients to providers more current? I don't know. You may have to ask the department on that one. But, I would have to say, with the new administration, Director Corcoran is someone who understands the provider community, has worked with the provider community before, understands these challenges and these issues. I think data is a big, challenging thing in healthcare. We can talk about electronic health records and their power, but you talk to a lot of physicians and they're like, why do I have these pop-up windows? So I think what we have to do is sort of take the long view around a lot of these things, which is to say, this is a really, really big ship that we're trying to turn here. And so it's going to take some time. As far as the attribution goes with the specific programs in the state innovation model, I think that, if anything, the federal conversation about changing those programs is going to necessitate a reconsideration, but also the state announced that they're looking into a pediatric comprehensive primary care initiative and are thinking about design there. So I imagine that many people on this call who may be participating in that or who work with their trade associations are going to have influence on that, and I would strongly suggest that gets brought up. So like I said, thank you for taking the time out of your day for this Lunch and Learn. We had over 170 registrants, which is great. I was unaware that many people would be as geeky as me, but I'm glad that we exist, and now we have this wonderful support group. But if you need anything, please go to communitysolutions.com. You can find our contact information, follow us online, sign up for a newsletter, and a recording of this webinar as well as the slides will be available on our website in the coming days, so be on the lookout for that. With that, I hope everyone has a great start to their week and look forward to seeing all of you soon. Take care.